Welcome to everyone to the OVOHT mini-series on data for performance and quality. We have two speakers this morning. Brian Snarch of the OVOHT Lead Performance and Analytics is going to be speaking on the launch of the OVOHT scorecard. And the second speaker will be Sarah Sell, the Manager of Lean Process Improvement at Pembroke Regional Hospital, and she will be speaking on how Pembroke Regional Hospital uses data for quality. We will go into the land acknowledgement. Next, I would like to acknowledge that we are meeting on the traditional lands and unceded territories of the Algonquin Anishinaabe people. We respect the long-standing relationships that Indigenous nations have to this land, as they are the original caretakers. We acknowledge historical and ongoing injustices that Indigenous peoples endure in Canada. We accept our responsibility to contribute towards revealing and correcting miseducation, as well as renewing respectful relationships with Indigenous communities through our work to create a more effective, efficient, and culturally respectful health service system in Renfrew County. Thank you. Now, Brian, did you wish to start a poll?
Yeah, I just popped it into the chat for everyone. Hello, everyone. We'll start off with a little quick poll about your organization's use of data, just to kind of take the pulse. Let me find the share button here. So the first question here, oh, sorry, we'll go back to the first question, Brian. Does your organization have a scorecard or a dashboard? If you click on that link, it should pop you up another window, and then you can put in your response there. Yes, we have more than one scorecard or dashboard, or we have one, or no, but something in similar related. No, all we do really is report to our funders, or we have our annual report. And then, maybe if you don't understand the question or it's not quite fitting your context, there's an option for that too. Just give this another couple of minutes or another minute. We have some heavy hitters on the data front here, I see, with quite a few in that first category. That's really interesting. Maybe, yeah, interesting. So quite a bit of use of data around the room here. I'll give it 10 more seconds to see if any more come in. We've got 9 replies. Okay, I'll move on to the second question. From 1 to 5 here, from not at all to all the time. Just pull the little lever on your, to what degree does your organization use data for quality and performance improvement, planning, and making clinical decisions, sort of clinical decision support? And then this shows the spread through the shape of the little wave there. And there's, I would say there's quite a heavy use of data on the quality and performance side and the planning side, and maybe a bit less so in terms of the clinical, the decisions for patients level. In the average 4.5 out of 5 there, so that's fairly substantial. A lot of people reporting all the time or almost. Okay, thank you for that. So it's a pretty sophisticated group here today, I would say. Let me pull up my slides next. All right, there's a couple of birthdays today. The OVOHT dashboard is 0, and I'm a little bit older than that, but it's my birthday too. So, so the OVOHT dashboard, it's a baby. Like, it has a lot of growing to do, but we all love babies, right? Sarah's going to talk about Pembroke Regional Hospital's processes, and from what I've seen, they're more solidly adult. Although I don't know if Sarah would characterize it that way, but of course we love adults and older adults as well. I'll go through a few slides about where the where this dashboard came from, how it came to be, like a little bit of maybe about the parents and why and how we made this baby. Then I'll show you the baby. First, I'll show you the pictures of the baby, and then I'll let you hold it for yourself because it's there online now for you to access. First, I just wanted to say a little bit about language. Like as Sarah and I were kind of comparing notes and preparing together, we were using different words for similar things. Like in some of the terms she was saying, like I didn't quite get and she didn't quite get. And so for people not deep in the work, like, and it sounds like a lot of you are pretty deep in the work, mind you. Some of these concepts overlap a lot. Like I was at a session for OHTs on Tuesday, and that title of that session was evaluation, but all these other terms came up too. I won't go into full definitions today, but I just want to note a few things conceptually, like quality improvement or healthcare improvement or health system improvement in green there, like that's pretty much always the goal. Quality improvement involves a set of tools and techniques and methods. And the rest of these concepts are more sort of data oriented. And really the activities are only really useful if they drive improvement. Performance measurement is an approach. Dashboards and scorecards are tools, and they have key performance indicators in them, KPIs, and that's what we look at to see if we're progressing in relation to our objectives. So there's a lot of terms, and you can make this stuff as complicated as you like, but I'm a fan of the maybe not quick and dirty, let's say quick and effective, like whatever you can do given the resources that you have. Anyway, if anyone wants a primer on this stuff, I'm happy to do that another day. And then let me go to the next slide. So our new dashboard, it's intended to be actionable, right? Like that we can see some stuff in there and move on it, not data for data's sake. We'll see how well we succeed. It's intended to be timely. Most things are updated quarterly. Like in some contexts, that's slow, but that's what's available in most of our data sources. And that's generally reasonable for system level kind of indicators. There's 19. We have a list of a few more that are in the wings, not ready for prime time yet. Alignment to provincial and local priorities is probably the most fundamental thing, and I'll say more about that. The objectives include tracking our progress against our work and measuring our impact. The expectation is that the dashboard will help drive some of our efforts and our focus to areas where we might be falling short of our objectives or where we might be performing poorly. And lastly, this is really intended to provide transparency to our members, to many of you on the call. Our little backbone team already had the data, but this helps to get it out to the partners as well. And then in a little green box, the quality improvement support enabler group, that's our, I don't know, what is that? Is that the parent or the grandparent or the godparent or something? I'm not really sure how far I can push this baby analogy here, but so we started back about a year ago, right? This is what comes before the baby. Okay, no, I'm going to stop right there with the analogy. And we figured out what this thing was for, what the approach and the principles were for selecting the indicators, the themes, the priorities. Next, in Q4 of last fiscal, we selected the indicators, and my next slide goes into detail on that. And then in the spring, we actually had a full first draft of the dashboard with data in it. And over the last few months since May, we iterated it and refined it and updated the data and changed some indicators. And so now that the baby's born, November 29th, comes the hard part, like getting it to do what we want it to do, which is to help drive change. Like we'll be working out the accountability mechanisms and how to ensure follow-up kind of iteratively. And I just want to note, like that works really well in an organization like Sarah's going to share, where the staff all reports up through the same structure, but it's a bit tricky, like that accountability piece in an OHT context where partners all have different priorities and different accountabilities. And last point, like on this slide, we fully anticipate changes. There's going to be changes to indicators. We're going to make this thing look a little prettier than it looks now. It's going to continue to evolve and mature. A little bit about the indicator selection process. First and foremost, we sought to anchor to our work. So we want to measure our progress on what we're committed to doing. It's kind of an accountability, really. More generally speaking, we've aligned to our local priorities and to our provincial directions. That includes metrics that are dictated by Ontario Health, which I'll mention. We scoured a lot of sources, including all the other OHTs that had stuff in the public domain and through and who agreed to share it with us. And we compiled a huge list of a couple hundred indicators to start, and then we whittled it down against a set of criteria. First, things where the OHT has a key role. Second, the maturity of an initiative really drove the select. Like, while we might really want to measure outcomes and impacts, some projects are just not that far along. So we measure something earlier along the chain, like the number of referrals or the number of people screened. Like, we might be really interested in their outcomes, but we can't quite get there yet. And data quality and data availability, major limiting factor. Some things that we really want to know just aren't available or easily measurable. The quality improvement group, steering committee, the data analysis working group all provided weighed in, and the QI group is kind of, like I said, the home for this project. And in the end, like for our launch, we have 19. As I say, they will change. I just want to show you a couple more slides drilling in on this anchor piece, the work plan piece, just to give you a flavor of the alignment. Like on the right here, we have our primary care indicators related. The ones in green are the cancer screening ones. And then you see the initiatives in green line up really, really nicely. Like, they're tight fit between those indicators and those initiatives. Then you have ED visits best managed elsewhere. That's things like colds and upper respiratory infections and otitis and cystitis, things that really you should be at a primary care doctor rather than the ED for. That's good primary care access kind of metric. Then we have a couple related to patient experience measures, people's involvement in their care and appointment availability. And those, so say the ones in white, like the fit is a little less tight, but really what we were going for was tighter fit where we could. One more example for the mental health and substance use health indicators. HEADS ED is a screening tool used by clinicians in the ED to identify the needs of mental health and addictions needs of kids and youth. And that metric obviously is perfectly aligned with our initiative. And then there's a range of activities in mental health and addictions at different levels, like from strategic planning to putting people with lived experience in the hospital to support the rounding and the work there. And so there's a bunch of things that have, let's say, a less direct line to the indicators, but still influence them. This is it's a challenge. It's a challenge, the alignment piece. Most of you are likely well familiar with the quintuple aim framework. Some people use a quadruple aim and treat equity as a kind of an overlay. And we organized our indicators into this framework. So I'll show you that here and finally get to the full list of indicators. You'll see that we bundled the priorities, sort of those bolded parts, where they best fit in the quintuple aim. But of course, indicators and priorities really fit across multiple aims. We put them where the fit seemed like most closest. In the first column, we have the reach of Ontario Valley Health Connect referral system. Then we have under primary care experience, patient experience, we have data from a survey from 3 family health teams. We saw those measures. We saw the measures on mental health a moment ago and primary care. Provider experience, like this is a gap right now. but there is data collected. Like I know that because we just did a scan of what health service providers are collecting from their providers. But we don't have data that's quite fit for OHT use right now in the provider experience. Under value of care, we have indicators on the rollout and use of online appointment booking in primary care, and some measures related to aging and community. ALC, that's determined provincially for all the OHTs. Actually, all the ones in purple come from our funder and dictated by Ontario Health. Then we have some long-term care and home care weight data. Those are things that the OHT activities don't impact super directly, but were deemed by our steering committee and by our quality improvement group to be important to monitor. So I'd say those green ones, they're more like monitoring indicators. They're not ones that we're so much accountable for. And lastly, while we don't have anything yet specific to equity, some of the other measures can be drilled down for different subgroups, so we can put that equity overlay. Okay, I'm getting to it. Dashboard is now live on our OVOHT members site for members to access. My apologies to colleagues from outside of the OVOHT. Let me pop the link in the chat. No, I'll do that at the end, so we don't, I'll do that right at the end of the session. Let me switch over and show you just quick a little bit of what it looks like. There we go. So when you go to the landing page, you'll see performance dashboard over here on the right. Is this coming through on the screen, everyone? No, eh?
Yep.
Do you see my web browser? Yes, thank you. Little blurb about it at the top, and then there's the view here. Let me just switch over to this view here. So you see the priorities nested underneath the quintuple aim. And let's just drill in on this one for an example. The 3 line graphs here are cancer screening metrics. You can see they've improved significantly over the last couple of years and are either just below or just above or right around the targets. And I'll add for cancer screening, OVOHT is in the top quartile among OHTs. So really very positive. ED visits best managed elsewhere. Let me just do you see the zoomed in version, Judy? You see this is the trend over time for this metric. We had a big spike in the fall of 22. That was RSV. So important to have that sort of context, right? Like what is going on? What explains what's going on here? And so the text over on the left is intended to talk a little bit about the context and about initiatives, especially about initiatives underway. So our team members provide some text and update that. And I'll just show you one more. This is not actually one of our official indicators, but we threw it in because it's a frequent topic of discussion and interest. This is a percentage and the number of people who are unattached. Actually, it's a slightly different measure. It's uncertainly attached, but close enough. And as you can see, very high percentages and numbers, particularly in Pembroke and Petawawa areas. Okay, I will just show you that there are these other tabs here. We won't look at them in any depth for time. I'll give you the link at the end of the call today. You can click around yourself, and then we got a set of definitions and a little bit about the scorecard. And there, I'll stop there. Just on time.
Yes, thank you, Brian. Are there any questions for Brian?
Thank you for these well wishes in the chat.
Yes.
Nice work, if I could say so. Very nice. Looking forward to poking through it.
Absolutely. Do other OHTs have dashboards as well, Brian?
Oh, yes. We did a scan in the early days and, sort of took some of their ideas. I was going to say it's interesting. The indicators vary a bit. Like they tend to have the shared ones from Ontario Health. Some of them have like really deep dives into very detailed data. Most of them are like ours, kind of high level. A number of them are more communications oriented, like kind of like a communications tool about what their successes have been. And we may use the data in the same way for some communications. And then lastly, I'll say like Archipel, which is the other OHT that I work with, we're going to take this OVOHT model and more or less replicate it into that context. So this will be used again in a different way.
Good. And what changes the indicators? What prompts the change of an indicator? Does it come from the province?
In part, like for example, the province has recently released a performance measurement framework for OHTs, and we'll be looking at integrating some of those metrics. And as they drop things too, we'll be looking at whether we should be dropping them. But then it's more generally, it's really about aligning with priorities, right? If our OHT decides to, let's say, elevate palliative care as a major priority, we will add some palliative care metrics. I think the challenge is going to be to not only add, but also to delete, right? Because it's easy to add and a little tougher to delete sometimes.
Excellent. Thank you very much, Brian.
Thank you.
Now the drum roll over to Sarah.
Thank you. Thanks. I recognize quite a few faces on here from my time at Community Mental Health. So nice to see some new faces and some familiar faces. Judy, you're sharing my presentation, right? Or am I?
Nope.
Nope, I am.
I think
Okay.
you are. Yep.
Let me just get it here. And do you see it?
Yes.
Okay, perfect. Still see it?
All good.
Okay, great, perfect. Thank you. So I'm here to talk about how PRH uses data for quality. And I would say, Brian, that we would be young adults. I'm going to say we're in our 20s here for where we are in this journey. So a few things I'm going to talk about today, and I forewarn you, I could talk for hours about this. I'm going to limit myself to 15 minutes. However, if there is anybody that wants to get in a little bit deeper into this, please reach out, and I'm happy to sit down with anyone and talk about it. So I'm going to talk about how we structure our priorities across the organization, how we get engagement and buy-in from our frontline staff, really, where we get our data, how we communicate our data and quality, and then give some real life examples of how we use it. So this is an example of how we structure our data. And we are really, really, really strict around everything that we do across our organization that is a top priority must fall into one of these little buckets. So the top one is really our True North metric indicators. So this is really how we measure, are we doing what we say we're going to do, and how are we doing over time? So these don't change much. These could be the same indicators for the next 10 years, 5 years. It's really how are we doing? And if anything prompts and we see something really going down, then that would trigger that it becomes something more than a True North metric. And then the next one over on the left is must do, can't fails. So this really is exactly as it sounds. This is what we must do, and we cannot fail on this. It's typically linked to our 5-year strategic plan. So what do we say in our plan that we're going to do, and what is a must do, can't fail that contributes to that? One of our senior leader team members are assigned to that must do, can't fail, and they basically are responsible and accountable for that to be successful. Next one over is quality improvement plan drivers. So Ontario Health tells us, gives us some priorities every year that we must work on, and improvement is expected on those within basically 12 months. We do sometimes, often have 1 or 2 on here that we have chosen based on some data that that we see something that maybe is going a little off track, we would then add add that to our quality improvement plan for the year. Caveat here is that to be a quality improvement plan driver, it really must touch kind of more than one department in our hospital. It has to kind of impact several of the departments. Then we have departmental drivers. So these are really quality improvement initiatives that are very specific to one of our departments. So each department at the beginning of the year sits down, thinks about, okay, what is going to be one or two of our main things, that improvements that we are going to really, really, really drive change forward on. And then they set that out at the beginning of the year and then work towards that throughout the year. And then the last one is our departmental watch metrics. And those are just department specific things that these departments are watching, monitoring. It's kind of like the department's True North metrics. How do I know I'm doing well? How do we know we're staying on track? And we're just going to watch that data. This is just a really, really quick slide on what our priorities are for this year. And then just note in departmental drivers and departmental watch metrics, that is not a full list of them across the hospital. Those are just kind of some of the themes that our different departments have chosen. Those aren't also just specific to our clinical departments. Our non-clinical or support departments also have drivers that they are trying to work on every year. And I'll just note, you see our care for our people, care for our community, care with our partners, and then an enabler. So like Brian mentioned, the quintuple aim, we up until this year with our new strategic plan, we followed the quadruple aim. So everything we did fell into one of the quadruple aim buckets. However, we now have since switched. We really wanted to drive forward and really highlight our new strategic plan. So we've switched actually that everything across the organization will now fall into one of the categories under our strategic plan. And how do we get engagement and buy-in? So data is a bit meaningless if nobody's looking at it or doing anything by it. So we really do try to get as much engagement and buy-in as we can from those people that are contributing to the work or impacted by the work. So first thing we do is we take the data and take the information out of the boardroom. That's so that you can see our strategy room with our senior leadership team. So this doesn't just sit in there. There are no secrets that hide behind a door. We get it out. We get it onto the units and onto the floors. It is available for everyone to view the most updated data on how are we doing. We actually moved our strategy room to a more central location. The door's unlocked, it's open. We try to host as many meetings as we can in there so that all of our staff can see exactly what we're up to and exactly what our organization's priorities are. And then change is driven from the front line to the boardroom. So this is an example of our discharge communication driver. So this is one of our quality improvement plan drivers this year that we're trying to improve on. And you can see at our bottom graph is our ED. So we have about 6 teams that are contributing to this quality improvement plan driver. So our ED team, this is data specific to them on this driver. So this is the question on the survey. Did you receive enough information from hospital staff about what to do if you were worried about your condition or treatment? That survey goes to our patients, and that is specific ED data that we communicate to the ED team. Listen, this is how the initiatives that you're doing to improve discharge communication, this is how you're doing, but then this is also how that is linked to our hospital-wide plan to improve communication. Next one to engage and buy-in is make it visible. So this is an example of one of our department's scorecards. You notice that we like red and green. We always explain that red and green doesn't mean bad and good. It can mean on track, or it can mean, you know what, I think this is worth just noting or watching or doing a little bit of a deeper dive into. So this is actually our AMH scorecard. Again, visible on we have huddle boards across our hospital. So AMH's scorecard is visible to all their staff to have a look at any time to see how they're doing on some of their key watch metrics for the year. I will just draw attention on this one too. If you notice along the side, there's a whole bunch of different names listed there, and that is then the people that are responsible for updating for that data and for updating that scorecard. So it is not one person that sits just at their desk and updates all of this. We all contribute and go in every month and update the data. And we engage the experts. So a big part of a lean principle is that the true experts in anything are the people that A, do the work, or B, are impacted the work. So we really every day make a huge effort to ensure that our experts are in our hospital and our patients and our stakeholders and our community members are know about and are engaged in any improvement that we do. This isn't something that we sit in a meeting room without engaging anyone. So these are just some of the ways that we do that. A lot of these are linked to lean management, but we make that effort every day to do this. And then we also talk about it. We have take a very structured approach to our communication plan. We ensure that our frontline are aware of what's going on at all our committees. These talking about quality improvement and talking about our drivers and our watch metrics and our true north is part of the standing agenda that we always talk about. It's not something that is kind of, oh, we forgot to talk about that in 6 months. Let's talk about it. Like every month, maybe even almost, I'm going to say to a fault, we talk about it a lot. So we just want to make sure that our governance, our board of directors, and some of our committees at a higher level are aware of how we're doing and what we're watching, and then try as much as we can to publish some of this to our public. I think we just had a PFAC, our Patient and Family Advisory Committee meeting this week, and they really stressed they think we should do a better job at this. They think we should do a better job of talking about what improvements and what things are we really trying to work on to improve here at organization. This is the list. There's about 20 places that we collect data from that feed into all of our quality improvement things. Some of these are, automatic. And some of them are very manual that we go around and have frontline staff do manual audits. We do brief weekly audits just to check in on how we're doing. And everybody, though, really does take a turn and have a specific responsibility around collecting this data. What's next for us? So I'm going to say we're just a young adult. And we're growing into midlife because we are in a huge transition to much more technologically advanced ways of collecting data. So as hopefully most of you know, we're going to Epic in the next year. We've just transitioned to the global workforce staff and physician engagement survey. So we're going to be doing that. We are part of Qualtrics now, a patient and family satisfaction survey, as well as the very exciting AI options that we have. But what we don't want to forget is while this is super exciting, we also remember that there's also nothing like some simple manual looking into data that we can do to be a bit more personalized. This is an example of our Qualtrics dashboard. So this is a new patient satisfaction survey that we have. And again, live data. Anyone, I can hop it on right now, see how this very minute how we are doing. We can delve into it department specific wise. We can look at overall hospital, how are we doing overall as a hospital. This is pretty new. I would say that we've kind of just started using this in the last 6 months, and we're having a bit of a hard time actually getting people to transition to looking at this. Everybody likes the red and green graphs on paper that get sent to us that we can look at. This whole idea of being able to go in every day and look at some of our data is just now starting to catch on. I'll give you a few real life examples of what we do. So this here is an example of our communication driver I had talked about earlier, and this is part of the Qualtrics data. So at any time we can hop on, we can see how we're doing this month on our surveys. We can see how many surveys are actually being returned to us. Do we need to do a little push in certain departments to get some more surveys back from patients and families? And then is there we can see right away some of our data dropping. Is there something happening on a unit? Is it super busy and we're getting not the greatest results? What do we need to do to improve those? What are we missing? We've also recently implemented ADUs, so automatic dispensing units, as a medication delivery system across our hospital. So huge change from how we delivered medications before. And we were really hopeful that the introduction of ADUs would have an impact on patient safety, on medication errors. So this graph really highlights, we implemented the ADUs in February, and now this graph, you can see it is covering incidences as reported by staff and near misses. So incidences are times that actually the wrong medication was delivered to staff or to patients, or there was some type of medication error happened. And then the near misses, which are in the orange, that indicates times where we caught a possible medication error or something happening before it reached the patient. So for the first time, you can see it got closer and closer, which is really, really good. And then at the first time in October, it actually crossed. So we had more near misses than we did patient incidents, than we did actual incidences, which means our ADUs are having an impact on safety, on medication safety here at our hospital. So we were really excited in October to see this. I talked way at the beginning about True North metrics and about those key indicators that tells us how we're doing on this in our hospital. So we had a True North metric of never events, so things that should never happen in the hospital. We had an incident in February of 2023 where we had a never event in our hospital. So that immediately turned from a True North metric into the equipped driver for the next year to ensure that that never happened again. So we really worked for the year of 2023, 2024 to improve that. Our OR team and our surgical teams banded together to ensure that that would never happen again. And since then, it has now moved back to a True North because we were able to maintain that for a year. And then my last example is really how we use frontline data to influence hospital-wide priorities. So in 2024, staff engagement was a priority for the hospital. We did our survey. There was a few questions on our survey that prompted us to think, uh-oh, we better do something to get this up, to improve it. We really weren't happy with the results. So we made staff and physician engagement a optional, like we chose to do it as one of our quality improvement plan drivers. We took our data, we took 3 questions that we really wanted to improve. And those were the senior leaders communicate organizational plans openly. I understand what the goals are for the hospital. And I can visually see how my department is doing based on some key metrics. Our senior leadership team did a ton of work over the year to improve those numbers. We did a brief snapshot survey mid-year, see how we're doing. Are we on the right track? We saw some improvements. So we're like, okay, let's keep trucking along. And we met our target of an improvement to 60%, agreed with those statements. But then we didn't quit there. So that was last year. So then this year we're like, you know what? I think there could still be a few departments that could improve on some. So this driver now, the staff engagement driver, became a departmental driver for about 10 departments in the hospital. So 10 departments in the hospital are continuing to work on staff engagement. So we didn't stop. It wasn't kind of a one and done. We rolled it out to now the next level across the organization. So a few lessons learned as young adults. Start and keep it simple. You tend to think, okay, I'm going to have to measure everything. We have to improve everything. Just start super simple. Really develop a structure. What is our structure? Is it under the quintuple aim? Is it part of your strategic plan? Develop a structure because language matters. People need to know what you're talking about and why it's important to our organization. Again, resist the urge to work on everything. Really limit the number of formats you use. So scorecards versus dashboards versus, like, people get confused. They're like, I thought we looked at here, but then all of a sudden it's there. So really try to keep it simple and limit the number of formats. A really nice thing to have is to align it to your strategic plan to make sure that you are prioritizing what you say you're going to prioritize. And then update the data at a frequency that makes sense. Most of our data is updated every month because that's just the groove that we've gone into and people are used to that. There's a few things we update quarterly for sure based on data availability, but for right now, we do update everything every month. And that's it.
Are there questions for Sarah? I have an introductory question. Am I, as a non-employee of PRH, do I have access to the dashboard on the website?
Not that I don't believe the dashboard yet, like it's
Okay.
pretty new for us, but we do
Okay.
have like our True North metrics and stuff on our website.
Okay, so that is accessible. Good.
Yeah.
Something that I noticed between both your talk and Brian's is the word aligning with priorities or with strategic plans. So that seems to be a common theme and makes perfect sense, doesn't it? And don't overthink it and don't check too often. We so.
Yeah. Yeah,
Those
when
are my
we have a
questions.
tendency for sure to, oh, we better put it on somewhere, we better and stuff. And it's just, then it just gets all muddled and nothing is meaningful anymore.
Start small and grow it.
Yep.
Yeah, absolutely. Questions? Okay, now, Brian, I think we have an evaluation that you're going to, oh, you have. Have
Just-
you?
Just put it in the chat.
Okay, lovely. If you wouldn't mind taking a moment or two to complete this survey, evaluating this session. And in the email invitation, you will have access to the speakers. If you find you have questions later on, you can reach out. I'm sure they will assist you.